This is Crystal Phend with MedPage Today here in New Orleans at the American College of Cardiology meeting, where I'm sitting with Dr. Gregg Stone of New York-Presbyterian Hospital in Columbia University Medical Center. So what were some of the highlights of the meeting for you?
Well, thanks. It's great to be here. I think this has been an exciting meeting. There's actually been a lot of important trials that I think will affect practice. Number one clearly was the PARTNER Cohort A study, in which patients who were high risk with aortic stenosis but were surgical candidates were randomized to either transcatheter aortic valve repair with the new SAPIEN valve versus traditional open heart aortic valve replacement. And basically the results were non-inferior. The trial was designed to show that the transcatheter therapy was non-inferior, meaning least as good as surgical aortic valve replacement in terms of prolonging survival or reducing mortality. And in fact, the mortality was almost statistically reduced with the lesser invasive transcatheter therapy compared to surgery. There were some different complication profiles between the two, but overall it was a very strong proof of principle that for high-risk operative patients, this lesser invasive approach, which of course is much easier for patients, is a real viable alternative.
So does this signal that we may be seeing interventionalists getting more into the area of valve replacement?
Yeah, I think structural heart disease is really a new area that interventional cardiologists are embracing. Both valves, congenital heart disease treatment, in the future left atrial appendage closure, and number one on everybody's radar screen is, again, non-operative aortic valve replacement. And so yes, I think you'll see programs be developed all over the country.
Interesting. We also saw a number of trials that were comparing sort of a standard treatments, namely the STICH trial. What do you think the implications are going to be for practice?
Yeah, well, STICH was very interesting because it was a very comprehensive, large clinical trial from the NHLBI that looked at 1,200 patients with severe left ventricular ejection fraction and severe coronary artery disease. And it asked the question, if we do bypass surgery in those patients, will we be prolonging their life? And everybody, I think, thought the answer was going to definitely be yes. And the overall primary endpoint of the trial was mortality, which was out at about 5 or 6 years, and it was actually a negative trial. There was a trend towards a modest reduction in death with surgery, but it wasn't significant. Now, after covariate adjustment and other statistical techniques, it actually was a significant reduction, and there were certainly other benefits in terms of lesser rehospitalizations for coronary disease or heart failure. So I think most people that have looked at it said overall mildly positive, but it wasn't the huge home run that people thought it was going to be. In addition, there was a sub-study that examined whether or not specifically doing bypass surgery in patients with bad left ventricular function in whom non-invasive testing showed that the heart muscle was still viable, that is alive, but perhaps hibernating and not contracting. And this sub-study asked the question, were those the patients specifically that benefited? And the sub-study did not see that those were the patients who specifically benefited. Although there were, again, at least in univariate analysis, some trends to suggest that that might be the case. So overall, STICH was interesting, but wasn't quite the home run that everybody thought it was going to be.
Mm-hmm. What about the rival trial? We heard that presented here too, radial access versus femoral access. Do you think that that is going to be something that we're going to see more of as well?
Yeah, this is a really hot topic. You know, radial access, I think, is a way to get to the heart to do coronary intervention or diagnostic arteriography. And it's been wildly embraced by some countries, certainly some individual operators, but some countries like Belgium and France, where the majority of the procedures are done through the radial approach. In contrast, in the United States, 96% or more of the procedures are still done by the femoral approach, which has been standard. And you have two very strong camps, the radialists and the femoralists, as they've been called. It almost sounds like the Confederate Civil War all over again. The radialists say that patients prefer this, and it is associated with less local vascular complications. But they also thought that because you decrease bleeding, which has strongly been associated with mortality in some of the studies that we and others have done, that actually it would lead to a reduction in mortality. And so the rival trial was a very large study of around 7,000 patients undergoing diagnostic arteriography with somewhat more than the majority also undergoing PCI, randomized to either the radial versus the femoral approach by fairly experienced radial operators. And overall, there was no significant difference in either mortality or cardiovascular death, myocardial infarction, or stroke rates. And interestingly, there wasn't even a difference in major bleeding or the need for blood transfusions. There were less local hematomas, there were less vascular complications, but that was kind of offset by, in about 1 in 14 patients, the fact that you couldn't get access from the radial artery. And so you had to cross over and go to the femoral approach. And there was somewhat more radiation exposure with the radial approach. So overall, I think this validated the radial approach for physicians who like to do radial intervention, but it also showed that the femoral approach also has its benefits as well. So kind of a win-win for everybody.
Mm-hmm. And we had some new data on drug-eluting stents as well. What do you think the take-home message is there?
Well, I actually presented some data called the Platinum trial, which was with a new platinum chromium everolimus-eluting stent, and we showed that it was non-inferior to the predicate cobalt chromium everolimus-eluting stent. And Dr. Marty Leon presented the US data from a large registry with a zotarolimus-eluting stent, and this had historical controls, and it was significantly better than historical controls. But the big take-home message with all three of these drug-eluting stents in these two trials were that the outcomes were phenomenal. And you were talking about 1 year event-free survival of around 96 to 97%, target lesion revascularization rates of 2%, stent thrombosis of 0.1 to 0.4%. I mean, the outcomes are getting so good with the newest generation of drug-eluting stents that it's almost going to be harder to improve upon this. And it really means that most studies that were done with older generations of bare metal or old generation, first generation drug-eluting stents are almost obsolete in terms of their outcomes. So good news for patients.
Yeah, that's interesting. Well, thank you, Dr. Stone. For InFocus, here at the American College of Cardiology meeting in New Orleans, I'm Crystal Phend, MedPage Today.